Have a good day. Today we are going to discuss about the topic pathology of jaundice. In the previous videos we have discussed an introduction about jaundice in the first video. In the second one we discussed about bilirubin metabolism. Now we are going to discuss about the pathology of jaundice or the causes of jaundice. What causes jaundice? Okay, so before that, before going into the pathology, I want to give a brief note about the intestinal phase of bilirubin metabolism. As I already told, intestinal phase is the last phase of bilirubin metabolism. Okay, so to the intestine, conjugated bilirubin is coming. Here is a pictorial representation of the whole bilirubin metabolism. So now I am just going to tell about the last phase, that is the intestinal phase. So you can see the picture. In this picture, we can see in the intestine, to the intestine, conjugated bilirubin is coming. In the intestine, three things are happening to the conjugated bilirubin. Okay. The first thing that is happening is the conjugated bilirubin is getting converted into unconjugated, which enters the enterohepatic circulation and again reaches the blood. Okay, the first thing is that. The second thing is, we already told that some amount of conjugated bilirubin will be reabsorbed from the intestine. Okay, but it cannot be reabsorbed as it is. Conjugated bilirubin is not reabsorbable. So we have to convert it into something. Okay. So the intestinal bacteria will convert the conjugated bilirubin into urobilinogen, which is reabsorbed from the intestinal mucosa, which enters the kidney. From there, it is excreted through the urine. That is the second fate of urobilin. It is the second fate of conjugated bilirubin. Okay. The third one is conjugated bilirubin is directly excreted through feces as stercobilinogen. Okay. These three things are clearly represented in this picture. Okay. One thing is it is converted into unconjugated bilirubin. Second is converted into urobilinogen. Third is its direct excretion through feces as stercobilinogen. Okay, so the next slide, it is just the two things. That is, it shows the direct excretion as stercobilinogen in stool, and the next one, it is its conversion into urobilinogen by the intestinal bacteria. It is the action of intestinal bacteria that converts the unconjugated bilirubin into urobilinogen. Okay, and I have also mentioned there as a point that conjugated bilirubin is not reabsorbable. Okay, so it is for the reabsorption, that is, we are converting the conjugated bilirubin into urobilinogen. So urobilinogen is easily reabsorbable. So we are done with the intestinal phase. It is a short brief. Okay. Next is the difference between the unconjugated and conjugated bilirubin. So we discussed many things. We discussed unconjugated bilirubin, conjugated bilirubin, its metabolism, jaundice, everything. So what are the major differences between unconjugated and conjugated bilirubin? In the first two column, I have discussed their difference, and in the third column, I have given a small explanation about it. Okay, so we'll take the first point, point A, that is the serum level of bilirubin. That is, if we take a sample from not a patient, from a human, if we check the blood serum, means the level of unconjugated bilirubin will be more. The level of conjugated will be less than 0.25 mg per dl. Okay, why so? Because we know that it is the macrophages, it is within the macrophages that bilirubin is produced, and this macrophages is producing what? It is producing unconjugated bilirubin. Okay, then this macrophages releases the unconjugated bilirubin to plasma. So if we take the blood sample means it will be unconjugated bilirubin, that is more. If it is only in the liver, if it reaches the liver only, then it is getting converted into conjugated. So if we take a blood sample means the level of unconjugated will be more. In the next explanation part, I have just mentioned the normal level of bilirubin, that is 0.2 to 1.2 mg per dl. Anything above that is hyperbilirubinemia, and if it to say it as jaundice means it has to be clinically evident and it should be above 2 mg per dl. Okay, so next is the water solubility. We already told that unconjugated is water insoluble. It will not get dissolved in water. Okay, it is for the water solubility that we are converting the unconjugated bilirubin into conjugated bilirubin. The first point that matters for conjugation, the first reason for water solubility is the conjugation. It is through the process of conjugation that the bilirubin is becoming water soluble. The next point is molecular weight. Its molecular weight. Conjugated bilirubin is very small in size and it is of less molecular weight. So it is easily soluble in water. Since it is of smaller size, it can be easily filtrated through kidney. And because of the larger size of unconjugated bilirubin, it is not water soluble and it cannot be filtrated through kidney also. Since it cannot be filtrated through kidney, it will not be present in the urine. Okay, the third one, that is C, the point C is the lipid solubility. As we all know, the water solubility can be due to another reason for water solubility is the polarity of the compound. That is, if that molecule is polar means it will be water soluble. That is, if a molecule is polar means it will be hydrophilic, that is water loving. So those molecules will be water soluble but will be insoluble in lipids. So conjugated bilirubin is soluble in water but insoluble in lipids. So unconjugated. So what about unconjugated? It is hydrophobic. That is, it is a weakly polar compound. Okay, and it is a hydrophobic molecule. Means it is water fearing molecule. So it is insoluble in water but soluble in lipids. The next point is the albumin binding. We discussed this in the bilirubin metabolism video that the bilirubin gets binded to albumin in the plasma. Why? Because for transportation, for further transportation, it should be binded with albumin. Okay, so albumin binding is high for unconjugated and it is less for conjugated. Okay, why? Because when the unconjugated bilirubin gets binded with albumin, then it reaches the liver. There it gets dissociated from albumin and the unconjugated bilirubin will get conjugated with glucuronic acid. Next is renal excretion. renal excretion, that is through transportation through kidney. That is, we already told that the unconjugated bilirubin is water insoluble. Since it is water insoluble and it has got a large molecular weight and size, it cannot be filtrated through kidney. Okay, but conjugated can be filtrated through kidney. Next is affinity to brain tissues. We know that to reach the brain, any molecule have to cross the blood-brain barrier. So, any molecule should cross the blood-brain barrier to reach the brain. So, as we already told, unconjugated bilirubin is lipid soluble. So, it can easily cross blood-brain barrier. Conjugated cannot because it is lipid insoluble. So, the unconjugated can easily cross blood-brain barrier and reach the brain. Okay. So, it has greater affinity for brain tissue and conjugated bilirubin cannot reach brain. Okay. So, it is the unconjugated bilirubin that is causing kernicterus. What is kernicterus? It is the jaundice of the brain. That is, in neonates, in newly born babies, this unconjugated bilirubin will cross the blood-brain barrier, reaches the brain and increases the level of bilirubin in the brain tissue. It can be fatal also. It can cause many neurological symptoms, motor symptoms, so many things it can cause. Okay. Next is the Van den Berg reaction or Van den Berg test. First, I'll explain what is Van den Berg test. It is a test to determine the type of jaundice. As you all know, jaundice can be either the increase in the level of conjugated bilirubin or it can be unconjugated bilirubin. So, if we want to know which bilirubin has increased, we will perform what? The Van den Berg reaction. Okay. So, here we are using the serum of the patient. We are using the serum sample of the patient. We are mixing it with the diazo reagent. Okay. So, if we mix the serum and the diazo reagent, we will get a red colored compound. Okay. If this red colored compound production is immediate, that is, we got the compound, the red compound immediately after mixing means the test is said to be direct. That is, it is the conjugated bilirubin that is increased. Okay. The next condition is we did not get any red color compound after mixing. So what we will do is we'll take the sample, first treat it with alcohol, then we will mix it with the diazo reagent. So it is after a while that is producing the red color compound. Okay, so that reaction is said to be indirect. So Van den Berg reaction has got two results, that is a direct one and an indirect one. Direct means the production of red color is immediate and indirect means it is only produced after treating the serum with alcohol then with the reagent. So in the indirect it is said to be, it is that unconjugated bilirubin that is increased. Okay. So unconjugated bilirubin will show a indirect reaction and conjugated will show a direct reaction. So I have finished with the major differences between unconjugated and conjugated bilirubin. Okay. Next is some extra points. These are three extra points. The delta bilirubin and connectors we have already discussed in the previous videos. If anyone want to refresh, I'll tell it now. So phenobarbital, it's just a extra point. That is, phenobarbital is a drug, as you all know. But the main side effect of the phenobarbital drug is it can impair the process of conjugation. That is, it will have an adverse effect on the conjugation process. Next is delta bilirubin and its half-life. So what is delta bilirubin? Delta bilirubin, it is a complex. It is a complex of albumin and conjugated bilirubin. Okay. So in the liver, we know that conjugated bilirubin is produced, and before the conjugation, another process is taking place. What is that? It is the dissociation of albumin from the unconjugated bilirubin. Okay. So after that only it is getting converted into conjugated. So this sometimes, if there is any cholestasis means, that is, what is cholestasis? It is called as obstruction. Okay. If there is any obstruction, which means there is a damage or the excretion of bile to the intestine is not taking place. That is, the bile that contains the bilirubin is not getting excreted from the liver to the intestine. So, if the conjugated bilirubin remains there for a long time, it will get bonded with the albumin and it becomes irreversibly bonded. Okay, that is, it becomes a permanent bonding. Conjugated bilirubin will get permanently bonded with albumin because there is no excretion, there is no transport taking place from the liver to the intestine. It is stuck there. Okay, so what it will do? It will go back to the circulation. There it remains for a long time. Even after the patient recovers from the disease, it will remain for some time. Okay. Then what will happen? Just mentioned its half-life. What will happen is the half-life, the plasma half-life of conjugated bilirubin will be equal to that of albumin, that is 14 days. Okay. Next is connectors that I already discussed. It is the neonatal, the neonates will be having jaundice. The bilirubin will be going into the brain tissues. Okay. Next is the pathophysiology of jaundice. Now we are coming into the causes of jaundice. So I'll brush up just a bit. That is, we discussed about the intestinal phase, just to give a brief note on the intestinal phase, and we discussed the differences between conjugated and unconjugated, the major differences. Then we dealt with the delta bilirubin, phenobarbital, and also connectors. Now we are coming to the causes of jaundice. What causes an increase in bilirubin production? What makes the serum level of bilirubin high? There can be many reasons. Okay. So these are the main 4 reasons for hyperbilirubinemia. That is, the first one is increased bilirubin production. That is something happening. The main source of bilirubin is what? We have discussed in the first video that RBC is the main source of RBC, or hemoglobin is the main source of bilirubin. So bilirubin is produced when the hemoglobin is broken down. So something is happening there. So increased bilirubin production. Then decreased hepatic uptake. The produced bilirubin is not taken by the liver, so it will get increased in the blood. Okay. Next is the decreased hepatic conjugation. The bilirubin that is coming into the liver is not getting conjugated. We know that for the further process to move on, or if we want to remove bilirubin, means conjugation has to take place. Conjugation is a mandatory process for its removal. So if it is not taking place, means the bilirubin is not properly getting removed from our body. So that also will cause the increase in bilirubin. The fourth one is decreased excretion of bilirubin to bile. So that is called as cholestasis or obstruction, like that. It can be due to many reasons. Okay, that is from the liver it is not getting excreted into bile. So I have mentioned here that in the first three situations, it will be unconjugated hyperbilirubinemia. That is, I'll explain to you. That is the bilirubin production. That the bilirubin that is produced first is unconjugated. So production increased means it will be unconjugated. Decreased hepatic uptake. There also what liver is taking the unconjugated bilirubin. If the liver is not taking the bilirubin means what will increase? Unconjugated will increase. Okay, hepatic conjugation. The conversion of unconjugated to conjugated is not taking place. So then also there will be unconjugated hyperbilirubinemia. So in these three cases, it will be unconjugated hyperbilirubinemia. In the last one, that is decreased excretion of bile. In the obstruction case, there what is happening? The conjugation has taken place. So now it has become conjugated bilirubin. From that step, the liver is not excreting the bile to the intestine. So it will be the conjugated hyperbilirubinemia happening. So that is the main four causes of jaundice. Next is, I mentioned just a test to determine the type of bilirubinemia. So to determine the type, we first discussed the Vandenberg reaction. Now we can do this test also. It's a simple test to determine the type of bilirubinemia. Okay. So, sorry, I have just written bilirubinemia. It should be type of hyperbilirubinemia. Okay. What we can do is, we can take the urine sample of the patient and we can test for the presence of bilirubin. If bilirubin is present means it is unconjugated hyperbilirubinemia, because only unconjugated hyperbilirubin can get excreted through urine, because only unconjugated bilirubin is getting absorbed by the kidney, not conjugated. Sorry, I've said it wrong. If the bilirubin is present in urine means it is conjugated hyperbilirubinemia, because only conjugated bilirubin can pass through kidney and gets excreted through urine. Okay. So we are done with the causes of jaundice. Now we are moving on to the classification of jaundice. We have a old classification and the new classification. Old is pre-hepatic or hemolytic. That is, it is happening before the liver. That is pre-hepatic or hemolytic. So before the liver means what? That is, there is increase in bilirubin production. That is, there is increase in breakdown of RBC. That is called as hemolytic. Next is hepatic. So before liver, in the liver and after the liver. Okay. So hepatic. Hepatic means what and all can be the causes. That is, it can be the reduced intake of liver. That is, liver is not absorbing the unconjugated bilirubin, or there will be any impairment in the conjugation process. Okay, that is hepatic. Now the third one is post-hepatic cholestatic or obstructive. That is, till the conjugation process it has taken place, but after that it is not getting excreted to what? Intestine. So there is some obstruction. Okay. Now, so that was the old classification. Okay. Old classification was like exactly based on the location. Where is the cause happening? Okay. So they divided them into pre-hepatic and post-hepatic. Now the new classification is based on the type of hyperbilirubinemia. So based on the type, it can be only two, that is either unconjugated or conjugated. So the first type is predominantly unconjugated hyperbilirubinemia. Okay, so we already told that for it to be unconjugated, there should be three reasons. What is that? Either it is increased bilirubin production, or decreased liver intake, or decreased bilirubin conjugation. There can be three reasons for that. So we'll discuss with the first one, that is increased bilirubin production, that is hemolytic. In that, what and all things can cause hemolysis? Either it can be intra and extravascular hemolysis, that is inside the vessels some hemolysis is happening, and or outside the vessel some hemolysis is happening. Outside the vessel means it can be spleen, liver, bone marrow, anywhere. Okay, so that destruction, that lysis have increased. It can be intravascular or extravascular hemolysis. The second reason is ineffective erythropoiesis. Okay, so we know that if any problem happens in the production means it will result in the damage of the product. We all know, no? That is, if there is any damage in the erythropoiesis means, what is erythropoiesis? It is the production of RBCs. It is the process of production of RBC. So if anything, if any damage happens in the erythropoiesis means there will be production of what? Impaired RBCs, which will get destroyed easily. So the produced RBCs is not good, so they will get ruptured easily, so there will be more bilirubin production. Okay. Next is decreased hepatic uptake. That is, the liver is not absorbing the produced bilirubin. So then also what will happen? The bilirubin level will get higher. Okay. So why the liver is not absorbing these bilirubin? It can be due to many reasons. It can be due to drugs. It can be due to prolonged starvation. It can be due to sepsis. Anything can cause this decreased hepatic uptake. Okay. The third one is the decreased bilirubin conjugation. So we have reached that they have produced bilirubin. The liver has absorbed that. Now in the liver it is not getting conjugated. Okay. It is not getting converted to conjugated. Then also what will happen? The level of unconjugated bilirubin in the blood will get increased. What can be the reasons? It can be any hereditary disorders, or it can be any acquired defects, or it can be neonatal jaundice. There are three reasons for that. Okay. So when we look into the hereditary disorders, I have given the examples as Gilbert syndrome, Crigler-Najjar syndrome, etc. Okay, what is Crigler? I'll not explain more about that. I'll give a short note. Okay, so bilirubin here, what is happening? The conjugation process is impaired. So we all know that for conjugation, which enzyme is needed? UDP, glucuronosyl transferase. Okay, Gilbert syndrome means it is the decreased activity of the UDP glucuronosyl enzyme. It is a hereditary disorder. Okay. Coming into Crigler-Najjar syndrome, it is the complete absence of the enzyme. That is, the enzyme needed for conjugation is completely absent in the patient. So, these can be the reasons for the decreased bilirubin conjugation. Okay. So, we are done with the unconjugated hyperbilirubinemia. Next, we are moving on to conjugated hyperbilirubinemia. Before that, I want to show you people the biliary system, how the bile is getting excreted or it is reaching the intestine. We can see in the liver, there are small hepatic ducts, which is not actually seen here. These small hepatic ducts join there are small hepatic ducts which joins to form right and left hepatic duct, which joins to form the common hepatic duct. This common hepatic duct joins with the cystic duct to form the common bile duct, which joins with the pancreatic duct and reaches the duodenum. So small ducts in the liver joins to form right and left. They both join to form common hepatic duct, which joins with the cystic duct. Common hepatic duct joins with the cystic duct to form common bile duct, which along with the pancreatic duct enters into the duodenum. This is the biliary tract or the biliary system. So the next one, that is the conjugated hyperbilirubinemia. Any obstruction in this biliary system can cause conjugated hyperbilirubinemia. Okay, that is, it is post-hepatic. Now, conjugated hyperbilirubinemia or cholestasis. Cholestasis means obstruction to the biliary system. Now, it can be divided into intrahepatic and extrahepatic. First, we discuss with the intrahepatic cholestasis. That is, it is the obstruction is inside the liver. We already told there are small biliary ducts which joins to form the right and left ducts. Okay. So it is in these small ducts that obstruction is happening. That is within the liver. It can be due to, so it is called as, the first reason for that is hereditary disorders. It is called as pure cholestasis. There are many hereditary disorders. Some of them I have mentioned here. That is Dubin-Johnson syndrome and Rotter's syndrome. Next is acquired disorders or hepatocellular cholestasis. Okay, that is, it is not hereditary. Through our lifetime we have acquired that. Okay, it can be hepatocellular cholestasis. It can be due to viral hepatitis or drugs or alcohol induced. Anything can be the reason for the cholestasis, for the intrahepatic cholestasis. Next is extrahepatic cholestasis. That is, the obstruction is outside the liver. Okay, so outside the liver means which are the ducts, that is right and left joint together to form common hepatic duct. From there, from that right and left hepatic duct, it is outside the liver. From there till the duodenum. Okay, so common hepatic duct joins with the cystic duct to form common bile duct, which joins with the pancreatic duct to form a duct to open into the duodenum. So from the right and left hepatic duct to the duodenum, any obstruction happens means it is extrahepatic cholestasis. That is, the obstruction is outside the liver. So there are many reasons in that. It can be gallstones, inflammations, tumors, or any mechanical obstruction. So we finished with the second one also, that is the conjugated hyperbilirubinemia. It is mainly due to the obstruction, that is the secretion of bile to the intestine is not happening. From liver to intestine it is not moving. So it is due to that bilirubin is increasing. Which bilirubin is increasing? It is the conjugated bilirubin which is increasing. So with this I have finished with the causes and classification of jaundice. I hope you have all understood. So thank you. If anyone have any suggestions that is regarding the topics taken, you can just mention in the comment box. If you like the video, just like, share and subscribe.